Awesome. So we're going to use this paper. So again, Continuum is the article that is a really good learning article for residents, and it's produced by the American Academy of Neurology. And it's my go-to for like really understanding the basics of like a specific topic. And so here, this is the article by Dr. Worrell that talks about evaluating seizures. And people can find this on PubMed. So what I was wanting us to do is just, they produce within some of their articles, they have cases, and we could just go through the cases, and then that will kind of help us with the high yield things or the big takeaways from this paper. So can you see my screen?
Yes.
Cool. So we're gonna get talk about seizures. So this case, it's a 13-year-old female who presents with recurrent spells of lightheadedness without vertigo. These occur more commonly when she stands up too quickly. So when we hear that, you have a young girl, has a lot of spells of lightheadedness. A key thing that they teach us in neurology is really trying to understand what patients mean by certain symptoms. So lightheadedness, although we think of it as one thing, patient may say lightheadedness and they may mean something else. So it's always really good as in neurology to really understand what the patient means by lightheadedness. So I'm assuming, because this is a case that lightheadedness means what it means, where you get that woozy feeling, feel like you're going to pass out, kind of like a pre-syncopal, but you don't pass out. And without vertigo is a specific sensation in which the room is spinning, but you're not moving. Like, you feel like the room is spinning, and that localizes to specific regions in the brain. So looks like we have someone new. We'll let them get situated. So that's what we have, lightheadedness without vertigo. So when I think lightheadedness, I think, could this be neurological or not neurological? Because there are other things that can cause lightheadedness that's not neurological, such as cardiac. So anytime a patient comes in and says, oh, they're lightheaded, they're dizzy, could this be neurological? Then if not, then then consider doing a cardiac workup. But usually these are kind of done in parallel, the neurological workup and the cardiac workup. So these happen when she stands up too quickly. So I'm getting the feel for, okay, this might be like orthostatic hypotension, where she stands up, her autonomic system cannot adjust quickly enough with the change in gravity. So when you're sitting, your blood pressure is, a certain value, but then when you stand, you get reduced preload because of gravity, everything's going down. And if your blood pressure can't compensate for that decrease in preload with the gravity, then your blood pressure is going to drop even more, less blood flow to your brain, and then you get lightheaded. So she's had two more of these events. One during a discussion on frog dissection in biology class. Another while
ding, ding.
Yeah. So what does that give you your vibe for?
Is that like more of a vasovagal?
Yeah.
Or like when you see the blood, it causes this vasovagal effect?
Yeah, exactly. And then one while getting her blood drawn, her eczema was normal. That's why I didn't go into surgery, because I get queasy very easily. Like I was in class today and they were showing us like surgical cases. I was like, and then the instructor was like, do you want me to? I'm like, it's okay. I'll just keep my eyes closed like this.
I remember that you kind of were panicked a little bit with that humongous clot that was retrieved.
Yes. Yes.
Love that.
Hi, we have someone new. If you would like to introduce yourself, feel free.
Hi, I'm not sure if my camera is working.
Not yet, but we can hear you. We can hear you fine.
I'm Carolina or Carol. I'm from Brazil. I'm a second-year medical student, so I don't know a lot, but I've been watching the other the study session that you sent today. I was watching it now, and I'm really happy to be here.
Awesome. I'm going to correct you. You do know a lot. You know, you know a lot to get to where you're at. So, you know, it's just learning more. So you know a lot, you've learned a lot, and we all learn from each other. So I welcome you to our study group, and I'm glad that you were able to. Hi, we see your video.
Great, now it's working.
So welcome to the study group. I'm glad that you're here. I am glad that we're able to get access to watch the other recordings. I've learned a lot from everyone, no matter what stage they're at in their training. And welcome.
Thank you.
So we just got started on talking about seizures. So feel free to chime in, ask questions. It's a very informal. We have, as Laura knows, we have a lot of fun here. And yeah, just whatever thoughts. And I like to know what level people are at, because then it helps me highlight things that are high yield for you guys at your level of training, for like taking board exams and step exams and stuff like that. So seizures is something that you'll see in your clinical rotations, very high yield. And so we're just going to be doing seizures and epilepsy for the next few days. So we were just talking about this 13-year-old female. We think, you know, she has this lightheadedness, and sounds like she also has some symptoms concerning for maybe like a vasovagal type response that's causing her to be lightheaded. So now we get an EEG, and it shows some independent bitemporal sharp waves in drowsiness and sleep. She was diagnosed with focal. So one thing to know, that the reason why we love to get people to sleep when we put the EEGs on them is because sleep, it makes seizures come out more for whatever reason. So she fell asleep and they saw
Sleep deprivation, or wait, sorry, I think I misunderstood that. Are you saying sleep deprivation, or during sleep you can see the like brain waves better? Or
it's during sleep. So what we tend to do is we tell patients to not sleep the night of getting their EEG, so they're sleep deprived. So
correct.
Then
Okay.
come in the clinic, they're going to fall asleep.
Yes.
Yeah.
Yes. Okay. Understood. Okay. Thank you for that.
Yeah, no problem. So they diagnosed her with focal epilepsy, and she was started on oxycarbazepine, which is an anti-seizure medication. She still has lightheadedness, and she still has 2 more spells. One before EEG, and the technician was rubbing her head, and the other was after she skinned her knee. During these spells, she said she feels woozy, look pale, and drop slowly to the ground. She lost consciousness, so now she had like a syncopal episode and remained limp for about 30 seconds, then gradually recovered over 2 to 5 minutes.
Ooh.
She underwent video EEG. During this time, the technician rubbed her head again to induce a spell, and they found that the spell was consistent with syncope, due to cardiac cause as opposed to seizure. So after careful review of her EEG, they felt that she doesn't have epilepsy. So the takeaway point is this case just talks about taking a careful history, distinguishing seizure from a non-seizure, and a diagnosis of epilepsy can't be made alone on EEG. So that's like the big picture. So now let's go. Let's break it down. So let me find my pen here. So in neurology, anytime someone comes in with loss of consciousness, lightheadedness, or dizziness, our job is to figure out, is this due to a neurological concern or is it not? So lightheadedness can definitely present as a seizure, because seizure is basically just overexcitation of a different part of the brain. And so if you get one of the parts of the brain that can lead to lightheadedness, then, that can present like a seizure. But some of the things that were kind of like, okay, well, this may not be a seizure is, like we were talking about earlier, it occurred during certain, it was predictable and it occurred during certain events. So when she would see something gross, then she got the lightheadedness. Sometimes when people get lightheadedness, you get an EEG, not always, more so you would do like a cardiac, it really depends on how the story sounds. I think in this case, if this patient came to me in clinic or in the emergency room, I wouldn't be quick to get a EEG, but there are times where you get EEGs and it's really spell classification,
Now, do you guys do at your house? Do you guys do EEGs in the ER? I just know some ERs are like they need to wait to the floor because unless we'll do an on-class CT, but as far as EEGs are concerned, like whether it be a 24-hour EEG or a continuous, are those usually started on the floor or?
Yeah.
Okay.
So if someone needs an EEG in the emergency room, then that's reason for admission.
Perfect.
Yeah. Okay. So if they're actively seizing, we treat the seizure, and then if we're not sure if the abnormal movements is a seizure or not, then we hook them up to EEG. But we don't hook them up downstairs in the emergency room. They get admitted either to the floor or to the ICU. So at this level, don't really worry about this bilateral bitemporal sharps. It's just an abnormality on EEG that could mean the patient is seizing or not. Don't worry about what that means. I'll tell you guys what's high yield to know. Hi, Seema.
Hi.
How are you?
Good. How are you guys doing?
Doing great. Thanks for joining.
Thank you.
So we're just talking about some seizure cases. And let me know whenever you're ready, and then we can do your TBI cases.
Sure. Yeah.
So don't worry about what this bitemporal sharp waves means. That's really it for resident level. Just know that because of this finding, they thought that she had focal epilepsy. She started on oxycarbamazepine. So for you guys, what's important to know about some of these drugs is their mechanism of action. And let's see if they talk about what the mechanism of action is, because that
I think that targets sodium channels, right?
That sounds familiar. Let me see if they say it here.
Caroline, there's other examples outside of like the seeing the blood, those prodromal sort of things that might be on step one. I actually did take step one within the past year. So other examples that you might find on the test, like the carotid hypersensitivity, where you have like the old man that's like buttoning his shirt and then it stimulates the carotid and then he passes out. That would be like the carotid stimulation. That's like part of like the category of like reflex syncope. And then sort of another example that you can kind of see if someone is like trying to void, either going to the bathroom, they're going to the toilet and they're trying to like void or like defecate, and then they like have a single flap. So that kind of lies under like that reflex syncope, where as well, like the vasovagal, etc. So that I did find. I actually specifically remember having the carotid hypersensitivity example on the exam with like the 80-year-old man buttoning his shirt.
Nice. Thanks. Here's a really good image. You're right. So let me see if I can pull this up. Let's visit this. What would I do without Google? So here we have, carbamazepine, oxycarbamazepine. Oxycarbamazepine is just a new formulation for carbamazepine. So they both act on these sodium voltage gated channels. A lot of these act on sodium. A lot of the seizure medications act on sodium. So those are the type of questions that will tend to show up on step one. Is really like mechanism of medication. So know that carbamazepine and oxycarbamazepine, phenytoin, valproate are calcium channeled.
Sodium.
Oh, sorry.
channel.
Ugh. Sodium. Thank you. Sodium channeled medications. Oh, I'm gonna copy this, and then I'll put this in the chat for everybody.
And then there's that one specific medication for absence seizures.
What is
right?
it?
And
then if anyone knows, you can answer. That's high
It is-
yield.
it's in the back of my head, and if I see it, I know it. But it actually targets calcium channels, I believe. It's very specific, and it's
It begins with an E.
Ethosuxamide.
Exactly. Yep. That's high yield too. Yeah.
Thank you. That was, did Seema help me? Thank you, Seema, for that.
Oh, I'm sorry, I was on mute. Sorry.
I'm like,
Ethosuxamide,
I
yes.
know what it is. If I see it, I know. But
Oh,
I
and
believe
see-
that one targets calcium, right? Calcium channels.
Let's
It's not a calcium channel blocker. It targets calcium channels. It's some sort of
let's
thing.
look it up. Let's see.
Some T-type.
Maybe this one has better. You're right. Good job. Calcium channel. I'll put this one in the chat too. Calcium channel.
In Carolina, that is very step one-ish. It's gonna always be like that 7-year-old child who's like looking to the corner of the room, not paying attention, and that's gonna be, and the teacher's like yelling at this, not yelling, let me not say that, the teacher's noticing that the child is not paying attention, and this is happening like 10 times a day, and you know, patient is doing poorly in school because of it, but really and truly, if the patient doesn't have like ADHD or anything, they're having absence seizure.
I like this. I like this image better. I'm gonna put this in my notes. So this one has the phenytoin, carbamazepine, oxycarbamazepine, lamotrigine, lacosamide, and all these other new medications. So if you forget, your best bet is to guess sodium channel for mechanism of action for seizure medications, because half of them are blocking the sodium. And then as we discussed earlier, ethosuxamide is calcium channeled. Keppra tends to be one that we like to use a lot because it's real tolerated. That one is SV2A. I don't know what that stands for. Does it tell us down here? Okay, synaptic vessel glycoprotein. But I think, yeah, knowing the channels is knowing like the ones that are voltage versus calcium. Those are, and then gabapentin. Oh, those are the big ones. This is a really good image.
And specifically, not just calcium channel, but like T-type, because there's different types. Like for example, Carolina, there's L-type calcium channels, there's T-type, and that is going to be very specific because you can have answer choice A, B, C, and D, and it'll be like, you just know calcium, but the answer will be like A is T-type, B is L-type, C is, you see what I'm saying? The same thing with the sodium channels. It's not just sodium. They're going to have, you know, it's going to be different types presented as answer choices. So they do like the little nitpicky stuff at that level.
Oh, looks like we have a new person. If you would like to introduce yourself, go right ahead. While I get this on. Awesome, awesome, awesome. Great learning, great teaching, everyone. So where were we? So again, don't worry about the.
I think that L-type channel that you're talking about was specific for insulin, right? I remember in biochemistry it's there. Right, Laura?
You're taking me way back.
That's
rather
a
not-
classic
I'd
step
rather
one
not redo-
question. Yes, yeah.
What was the answer?
So that is specific for the insulin channels in biochemistry for the L-type.
Oh.
Yes.
And so
Well,
actually, I just
that's
even noticed.
That's 10 years
I-
ago for me. Woo.
Okay.
But even with like the GABA, so GABA, there's like different subunits. So you have to know like, okay, benzodiazepines target GABA like alpha subunit receptors versus like, for example, barbiturates target GABA B subunit, beta subunits or something like that.
Yeah.
That is very specific to step one, knowing, because again, both answer choices will be presented. Very, very specific. So here it'll just say GABA, but on the exam it'll have very, very specific subunits.
Oh,
Right, Seema?
Yes, yes, yeah.
awesome. I'm loving this because I forgot a lot of stuff that you guys mentioned. So see, this is why I say we all learn from each other. So we talked about oxycarbamazepine, lightheadedness persisted. She had more spells, one just before EEG when technician was rubbing her, the head. Again, it's associated with a specific maneuver that is not typical of causing seizures. So that is like, could it be something else? And then one after she skinned her knee, again, skinning your knee, that's not trigger for getting a seizure. So it's like, okay, what's going on? And then with these seizures, she felt woozy. Now with seizures, you can feel all kinds of things. I've had patients feel like they would see like kind of auras, they would have like upset stomach or like GI symptoms or kind of nauseous or vomiting. So woozy, that could fit a seizure semiology, but in context. She looked pale. Again, seizure doesn't cause you to be pale. When I think pale, I think, lack of blood flow to the brain, lack of blood flow to like, skin, decreased heart rate. And then she dropped suddenly, she dropped slowly to the ground. When you're seizing, you don't drop slowly. You no longer have control, especially if it's tonic-clonic. You no longer have control of your limbs. You go from singing, then you just hit the ground. So the fact that she dropped slowly is kind of like, okay, well, that's not typical for seizures. She lost consciousness. If you have a generalized seizure, you can lose consciousness in that you're no longer responsive. But this sounds like she blacked out and she remained limp. So again, that is kind of painting this picture of a syncopal episode. It lasted 30 seconds. Again, seizures, can last seconds to minutes. If it's their status, then it can last longer. Then gradually recovered over 2 to 5 minutes. That is not typical of a seizure. So with seizures, you have the pre-ictal state, you have the ictal state where you're actually having the seizure, and then you have a post-ictal state. And the post-ictal state kind of lasts hours. You're groggy, you're confused, you just had this like bolt of lightning striking your brain and you're just trying to recover. The fact that she recovered within 5 minutes is too quick for it to fit a seizure semiology. So she undergoes video EEG, which is different from probably the first EEG. So we have two kinds of EEGs that typically gets done. You have the routine EEG that's about an hour. So usually you can get that in the hospital or in the clinic. And then you have a video EEG, where it's just is longer than an hour, usually a day or two, depending on what the context is. So they felt that, well, we need to tease out what this spell is, and let's capture it, and let's get a longer EEG, which they did. And then the technician did something great. He or she knew, well, she has these spells with certain maneuvers, so let me trigger those maneuvers so that I can elicit this abnormal response so that they can capture it while she's wearing the EEG. So they did that, and they noticed that she had the spell, but there was no seizures on EEG, meaning that what's going on is not due to a seizure. So they can stop the seizure medications and they can work her up for other causes of syncope. So they work her up due to be cardiac. Again, don't worry about the 14.6 positive spikes. That's more so for residents. So there you go. So I think the takeaway for the med students is to kind of know that, kind of know how seizures present, and this really is not typical of a seizure. What is typical of a seizure? What are the symptoms of seizures that you guys have seen?
Are you referring to presentation or
Yeah. So let's say we're in the ED because we're focused on ED, and the patient has a generalized tonic-clonic seizure. What are things that the patient's going to be doing?
So you will see to break down tonic and clonic, and this is this is way far beyond my, but I will say there's motor move, when you see and you usually see, oftentimes with seizures, you see it start and then you see it progressing to the other side. If it starts with the left arm, you can see it actually progressing to the right arm. You can see very rigid body movements, arching of the back, movement of the head to a specific side, fixed to a certain side. A lot of you can even hear a lot of mumbling or I guess, and you can even see for instance in patients who lose consciousness, even they can have respiratory depression, foaming of the mouth, very right. So hard for me to explain because this is honestly very
no,
this is not something that I'm not that good at this part.
No,
Bowel movements sometimes.
Yep.
Yeah. Oh yeah, incontinence spells. Yeah, that's very common.
So the key things to know, anytime a patient comes in and they have a spell, the things you want to be asking them, when you're talking to the witness as part of your HPI is, were there any abnormal movements? If so, what were they? And then you can kind of act it out. Was it like this? Was it like this? Was it like this? Or was it were they stiff? Was it the hands? Was it the legs? Was it both? So movements, you want to ask, were they stiff or were they shaking? And you want to use layman terms because they're not going to know what tonic-clonic is. So just acting it out, I've noticed is helpful for people to say, okay, I want you to show me what you saw on your body. And then I can write that down. And then you want to say, was it one-sided? Was it both sides? Sometimes they're I don't know, I was just freaking out. And I'm like, okay, that's cool. Just whatever you think you remember. So motor is key. Another thing is, what were their eyes doing? Because seizures, if it deviates to one side or the other, that can help you localize, what side of the brain it is. So were their eyes, and a lot of patients, a lot of witnesses were I have no idea, I don't know. But, were their eyes deviated to the left or to the right, or were their eyes shut really tight? Sometimes patients shut their eyes, and if their eyes are shut, then that makes you think, well, is this really a seizure? Because with seizures are activating, and people tend to keep their eyes open during seizures. And if their eyes are shut, you're like, But it doesn't mean that if their eyes are shut, then it automatically rules out a seizure. But another thing you want to ask is foaming at the mouth. Were they drooling? Is there blood coming out? Because when you're seizing, one thing we always tell people, never put your hand inside a person's mouth who's seizing, because you're going to get, your hand's going to be bitten off, because they have so much force and contraction of their mouth that, people have gotten their hands, and sometimes patients who are seizing bite their tongue on the lateral aspect of their tongue. So if a patient's witness says, yeah, blood was coming out their mouth, that means they probably have some tongue injury. And like Seema mentioned, you also want to ask about bowel urinary incontinence, because that sometimes can happen. And, did the patient wet themselves? Another thing you want to ask, so once you talk about the actual event and just try and get a recollection of what actually happened. Oh, we have another person. Feel free to introduce yourself if you would like. Then,
It's the same person. My name is Ernest.
hi, Ernest. Nice to meet you.
Nice to meet you. Nice to meet everyone.
Welcome. Where are you studying from?
I'm currently in the US. I'm IMG, so I'm studying for step 3.
Nice. Welcome. There's
you.
seizures are highlighted on step 3, so we'll be sure to drop some pearls. Thank you for joining. And then feel free if you have questions, comments, additions. It's very informal. We all learn from each other. So welcome.
Thank you.
What was I saying? Oh yes.
Like recollection of events pre, during, and post, and the fact that oftentimes patients shouldn't recall events, and so if they do, would you be suspicious, that they can recall all the events?
If it's a focal seizure, then they don't lose overall awareness. If it's a generalized tonic-clonic seizure, then one of the criteria is loss of complete awareness. Let me find. So here's the new seizure classification. There you have focal seizure, you have focal onset, generalized onset, and then unknown onset. So within focal, you can have 2 types. They're aware of their surroundings or it's impaired. So we no longer use like petite, grand mal, we don't use that.
So are we not using like simple focal and complex focal to differentiate aware and unaware anymore, or the terminology has changed?
I think that's changed. I think now what we're using is focal onset with awareness, focal onset with impaired awareness.
That actually makes more sense. It's more intuitive that way. I like that.
Yeah. And then after we talk about whether the patient's aware or not aware, then we get into is there a motor component or not a motor component? And as we talked about, seizures can present all kinds of ways. And for the non-motor, you can have like behavior arrest, cognitive, confused, emotional, and sensory. And this autonomic is where like heart rates and respiratory rates and blood pressure, things like that. So then that's focal. Focal means it's only one part of the hemisphere. It's not both. If you have bilateral involvement, if you have involvement of both hemispheres, then that is going to be generalized. And you will have impaired awareness because you have both hemispheres that are involved. So with generalized epilepsy or generalized seizures, there's 2 kinds. You have motor and you have non-motor, and that's more so the absence seizures. So with motor, you can present, differently: tonic-clonic, clonic, tonic, and all these other different kinds. The most common ones are tonic-clonic, clonic, and tonic. So tonic-clonic is like, you stiff and then you're jerking. That's pretty much that one. And then unknown onset, you guys don't really have to worry about that at this stage. That's more at the resident level. It's just, it's not focal, it's not generalized, it's unknown or unclassified. So that is how we diagnose and that is how we classify seizures. I'm trying to think, was there anything else I wanted to say with this? So when you're gathering information, those are the questions you want to ask. Is there a motor component? Did they lose awareness? Is there foaming at the mouth? Any bowel urinary incontinence? How long did the event last? That is so key. Did it last 30 seconds? Did it last a minute? And after the event was finished, how was the patient? Were they responsive? Were they sleepy? Were they drowsy? Were they lightheaded? Because how seizures, let me pull up seizures. seizure stage. Okay, here's how where I'm getting at with respect to pre-ictal, post-ictal, ictal. So they call it prodrome of, okay, for example, I don't feel so good. My stomach is in knots or nauseous. And then you get into the prodromal oral. And then when the patient's actually having a seizure, sometimes they have like motor seizures, the actual seizure is like the shaking of the arms or the legs. And then the post-ictal phase is when the seizure stops, either clinically or on EEG. And that post-ictal, as this image is shown here, the person is, confused, thinking, mood, more irritable or just sleepy, and just kind of withdrawn. And that lasts hours, not minutes, like in syncopal episodes. So that's kind of the phases of seizure. So if you're asked to go talk to a patient and they kind of talk about, yeah, I think this person had a seizure, you want to be asking about these stages. Well, how's the patient before? Did they complain of any abnormal symptoms? Then the ictal state and then the post-ictal state. And if they have very concrete, if their symptoms fit each of those sections, then more than likely it's probably a seizure. Okie dokie. And yeah, I think those are the big things. It's really determining, is this a seizure, not a seizure? Because once we know it's a seizure, then we go down a different pathway. But the first question is this a seizure? Or did the patient have a seizure and that's why they came into the emergency room? Any questions on this so far?
More of just a comment. So, like, and just more so just to just kind of support exactly what you were saying. Like when someone comes into the ER with a suspicious, seizure as a differential, because apparently not everything that seizes is a seizure. So it's incredibly important when it's someone's first seizure, or just suspicious for seizure. It's like looking for everything known to man that could be the cause if they don't have a history of seizure. So like, is there any sort of electrolyte problems, like tumors, or just thinking about anything possible that could have triggered this seizure. So just something like the initial management of that patient is going to be outside of when you do the A, B, C, and D, like, air, breathing, circulation, and all that of the patient, really finding out what the actual cause. And in this case, actually, there's just the patient has some cardiac problems. So
exactly.
You're ruling out seizure before you rule it in, almost, if that's their first seizure, really. Exactly.
And that's another thing is evaluating, once we get their seizure under control. Well, first question is this a seizure or not a seizure? And then if we think it's a seizure, then we do, okay, well, what caused the seizure? What are some of the etiologies? And there's a vitamins mnemonic that's very popular that a lot of individuals use to remember what are the causes of seizures. And I think we'll get to that later down the road. But the first thing is to determine, does this spell sound like a seizure based upon all the things that we talked about? Okay, so now we can go to the next case. We have a 19-year-old female presents with her first generalized convulsive seizure. She had been up late the night before and had a 3-minute generalized time-calming seizure witnessed by her roommate. So again, anytime someone has a spell, you always want to ask, you want to figure out who witnessed it. And then you want to talk to that person. And I do that all the time. If I go see a patient and someone says, well, yeah, they acted weird, I'm not going to ask the patient too much because the patient may not be able to remember, especially if their brain is seizing. So I'm always asking for collateral. Who witnessed it? And I try and speak to that person, whether it's EMS or the nursing home or a partner or a family member. So that's always key. And that will get you brownie points. If you know that early on in neurology, is always asking a witness for spells. So witness approximately 10 minutes after getting up from work, she didn't have any auras during the seizure, so she loses bowel incontinence. So we talked about how that can be a finding for seizures. It's not too common, but you know, if they have bladder incontinence, then you're like, okay, well that could support having a seizure. Person bit the side of their tongue. Again, no one bites their tongue on accident. Especially this, like, because that hurts. So again, that's supporting that, okay, well, this sounds like it could have been a seizure. And her exam 2 hours after the seizure was unremarkable, and her baseline, her electrolytes were normal. So sounds like she was sleep deprived, which probably triggered her seizure. Roommate solid. She lost bladder incontinence, and she bit the side of her tongue. To me, and she had abnormal jerking movements. That sounds like a seizure until proven otherwise. So they check her electrolyte panel because, as Laura was getting at, okay, well, we think she seized. Why did she seize? Could it be sleep deprivation? Could it be something else that added to it? Could her electrolytes be abnormal? And so that's why they were checking the BMP, which was normal. And then, you know, family history, her aunt has epilepsy, and seizures tend to have a genetic component. So they do an EEG, which is basically a device where they put a bunch of electrodes on your brain, and they're really just monitoring for brain waves. So because although her event smells like a seizure, the only way to definitively say this was a seizure, that she has epilepsy, is to do EEG. So that's why they wanted to do the EEG to see, does her brain show findings consistent with EEG, with epilepsy. So they do EEG and they see abnormalities. Don't worry about the abnormalities. This one won't show up on your exam. And they did light, because there's certain things that we call activating techniques to help bring out seizures. One is the patient being sleep deprived so that they can fall asleep. Another one is light. So a high yield for your exam is know that when you do, why am I drawing a blank? What activating technique is associated with absence seizures?
Oh, are you talking about the 10 hertz spike? Or wait, sorry, I think I missed the question.
That's
Are you
okay.
talking about-
So has anyone heard of hyperventilation in absence seizures?
Oh,
That
no,
is
I
very
haven't.
high yield. Yeah. So if we are concerned that a patient has absence seizures, or seizures where you're steered off into the distance, it's really found in childhood. And the typical story is, oh, we have this kid, and when the kid is in class, they just stare off and we think they're not paying attention, and they do it multiple times a day. They are not participating in conversation the last second, and then then they're back to talking. So that's kind of how it presents. And so what we do in those situations, well, it sounds like absence, but we need proof. We hook them up to EEG and we tell them to breathe really, really, really fast, because it brings out absence seizures. And the buzzword, so things to know about absence is it's usually happens in childhood. It's brought out by hyperventilating. You treat it with exosuccinimide. Did I say that word right?
Yes.
And it's 3 hertz. That's
3, yes.
hertz.
3 hertz.
3 hertz.
Yes.
Let me double check.
3?
I think it's 3.
Or 10?
Hertz.
That was actually very high yield, and now it's in the back of my brain.
Oh, there's a lot of things that are no longer in my brain. They were there once. So
yeah, 3 hertz spike sounds familiar though.
So remember that. So remember, those are all the things you need to know about absence seizures. for the boards. 3 Hertz, brought up by hyperventilation, associated with childhood or kids, and treat with exosusamide. Exosusamide. They need to make these drugs less syllables. Make sense? Cool,
That's
cool.
actually so high yield. That is actually so high yield. Yeah.
The hyperventilation, it only works for absent seizures, or
Yeah.
you can, okay.
Yeah, we don't tend to do it in others. For whatever reason, it brings out absence. I don't personally know the mechanism behind it. I don't know if it's well known, but it brings out seizures.
You know, very unfairly, I actually got pimped on juvenile myoclonic epilepsy, and I was a nurse. I was pimped by my mentor,
What?
a physician.
Nonsense.
And he was like, what is nonsense? Yeah. Like, what is the most effective drug to treat juvenile myoclonic epilepsy? And I was like,
What is it?
It's valprogatin.
That
And I will never forget that.
Because they ask me that a lot, and I'm like, going through
It
the
is
list.
valprogatin.
Valproic acid. Okay.
Yeah.
Juvenile
There's some-
myoclonic. Let me write that down. Juvenile myoclonic epilepsy.
Correct.
Okay,
Yeah.
hold on. Let me get my pen.
I can't believe I was pimped as a nurse.
You be like, next time just be like, I don't need to know that.
Right.
You better ask somebody else. Not nice at all. So let's see, juvenile. Valproate. Cool. Valproate. Cool. So those are the big things I wanted you guys to kind of get out of this one. She was admitted to episodes of hand twitching in the morning that caused her to spill her tea, but attributed that to nervousness based on the EEG. Oh, well, there we go. Diagnosed with juvenile myoclonic epilepsy, and an anti-seizure medication was initiated. Don't worry about this figure. You will never see this. Don't worry about it for now. So this case, so their takeaway was this case emphasizes that the first convulsive seizure that typically brings the patient to medical attention. Many patients present with the first seizure, have a history of prior seizures that may not have been recognized. Oh, so they're saying that when she spilled her drink, that was possibly a seizure, not nervousness. Because have you ever spilled your drink because you were that nervous? That's you must be very nervous to spill the drink. So that's what, okay. May not have been recognized, does have epilepsy. In this case, the hand twitching in the morning was consistent with early morning myoclonus. Okay, so big takeaways is witness. I've talked to the witness. Some symptoms for seizures are bowel, bladder incontinence, tongue biting, abnormal arm and leg movements. And they will ask us on step 2, what's the next best step? And someone who you think is having a seizure, what's the next best step? And the next best step would be to get an EEG. They'll ask that. Cool. And we talked about this, about classification for seizures. You know, focal onset, there's 3 big categories: focal onset, generalized onset, unknown. Focal, there's 2 subcategories, major ones. What's the patient's alertness, and then motor, not motor. And then for generalized, they're automatically going to have impaired awareness. So you're really trying to figure out, is it motor, not motor? I like to repeat things because it helps me learn it too. It sticks in my head.
Dr. Igadora, actually, it just something just kind of came back to mind in regards to juvenile myoclonic epilepsy, only because I name dropped a drug, valproic acid. Just be careful with that medication because that is contraindicated in pregnancy. So that is a very
why?
medication.
Why is it contraindicated?
Is it neural tube defects or?
Yep. Yep.
Yeah. So just FYI.
Oh, here's another question. What for females who are on valproic acid, who are getting pregnant, what supplement should they be on to reduce neural tube defects?
Phenolic acid. I
Yeah.
think what the dose
Yep.
is like, it's significantly higher than the
Yeah.
general population. I don't know. Don't quote me. I think
Oh, I
it's
don't know
definitely-
either. But that's high
Uh,
yield. That's high yield for probably step one. Neural tube defects, folic acid. You get folic acid, it helps reduce, even if they're not on seizure medications, a pregnant or they say what female childbearing age, they should be taking folate. I want to say 1 gram. I don't know. Don't quote me.
I
don't know.
want to say so. I think 1 gram is for the. 1 gram is for general population, but I think for women that require more, like because it's like certain medications, I want to say it's like the high dose for neural tube defects. It must be like double that or something. Something really interesting. Something like that. We'll see. Let's see what we come up with. Up to date.
Oh, here we go. Let's see what does up to date say. Dose, okay, for most women, the standard folic supplementation is 0.4 milligrams once per day. Okay, fantastic. And then high yield. So for high yield mothers, it's 1 to 4 milligrams for supplementation. Okay, there you go. So between 0.4 to 4 milligrams. But just know, neural tube defects, oh, check this out. A lot of the seizure medications cause neural tube defects, like phenytoin. These are just other meds.
In fact, speaking of that, I believe I just remember one particular medication, but there's certainly probably more. I just remembered like lamotrigine is like the good go-to for epilepsy medications for pregnant women. Yeah, I just
there's actually an article on seizure medications in pregnant women that we can talk about in an upcoming study group, because they're starting to talk about that more, given that it's a very high yield topic in neurology.
Yeah.
Awesome. So we talked about case 2. Don't worry about this. This is for residents. I think there should be another case. They love to do 3 cases. Okay, case 3. We have a 9-year-old boy who was well. He comes to the emergency department, our favorite area of the hospital. Witnessed. He has a witnessed first generalized tonic-clonic seizure that occurred at 6:30. Mom was getting ready for work and heard choking sound from his son. Oh, goodness. Found him having a convulsive seizure lasting 3 minutes. He bit his tongue. Okay, that's fitting the semiology for seizures. Ambulance was called, taken to the ED. His exam, he had weakness on the left arm and face that resolved within 30 minutes. His MRI was normal. So one thing that tends to happen sometimes in patients that have seizures, they can have, after the seizure is finished, they can have a TAS paralysis, where they have weakness of the extremity or the face, and it's due to the activation of the seizure. So that's what they're getting at here. He had weakness of his arm and face. It resolved. MRI is normal. He does not have anything. Go ahead.
Quick question. The brain MRI, do you mind just telling me exactly why? I'm assuming the brain MRI was done only because, are we just ruling out like tumors and AVMs and anything like that? Or, okay. Yeah. Okay, fair.
Ruling out. Fair. And then, because when someone has left-sided weakness, it's like, did he have a stroke? So the MRI can tell you stroke, no stroke, and it can also say, is there something underlying that's causing this person to have a seizure? Typically in the ED, you'll get a CT head. I want to get an MRI until he's admitted to the unit, and then that's when we're going to MRI, at least in our hospital. He doesn't have any medical history. Excellent student. And the reason why I suspect they say excellent student is because sometimes kids that have seizures, some seizures correlate with syndromes with reduced developmental delay or the developmental delay. And that can be a syndrome that's associated with seizures. Or if he was doing poor in school, it'll make you wonder, does he have some underlying epilepsy that has been undiagnosed? But he's doing well in school. He had 2 brief episodes over the last 6 months where he woke up in the morning and felt like he was drooling. His left mouth was numb and he could not speak clearly, although he was alert. Why is it so if he's alert, can he have a generalized tonic-clonic seizure if he's alert? Exactly, because generalized tonic-clonic seizure involves both hemispheres. So both hemispheres are involved. Your brain, I mean, there's no other, your alertness, it's a complicated pathway. But you need your cortex to be alert. And if your brain is seizing on both sides, you're not going to be alert. So he's alert, so that means it's a focal seizure that he's having, and he's only having symptoms on one side. So again, one-sided symptoms, it's going to be focal. This resolved within 1 minute. Family attributed these to normal sleep variant. They do an EEG to figure out all this sounds like a seizure, so we need evidence. We get the EEG, shows that he has abnormalities consistent with seizures. Don't worry about what the abnormalities are. Based on his history of EEG, he was diagnosed with epilepsy, and that's pretty much a big thing. So this is just kind of big picture. He's having these events. They don't sound right, sound like seizures. Get an EEG. EEG shows that he has seizures. You start him on the appropriate medication, and he gets better. That's the big takeaway. Let's see what else they wanted. Yeah. So there's specific syndromes that you don't need to worry about for now. So that's the big thing for seizures. So that's kind of like big picture seizures. I think those are all the cases from this paper. So the big takeaway from these cases and these discussions is really recognizing how seizures present. And when you go down to the ED and you're getting the history, there's certain things that you have to ask, like we talked about, and that can, you want to, and that can help you figure out, is this seizure, not seizure? Because if you're convinced it's a seizure, then you go down a different pathway. And we can kind of talk about, if you're convinced it's a seizure, it's their first seizure, we can talk about the vitamins mnemonic, because that is big for step 2, step 3. And this is a mnemonic that you can use that can help remind you, what are the things I need to be looking for if I'm convinced that a patient has had a seizure. So here, this is going to take me to Pinterest. Oh, goodness. So here's a good mnemonic for seizure. So if a patient, you guys can't see my screen, can you? Never mind. Let me share my screen. So here's a mnemonic, vitamins, and it stands for high yield pathologies that can lead to seizures. So if I'm convinced a patient has a seizure and I've already treated their seizure, they're no longer seizing, you got to figure out, well, why did they seize to begin with? So this will help you figure out your differential. Seizures, could it be due to a vascular etiology? Like, did they have a stroke? Did they have a brain? Well, not stroke. Did they have a brain bleed? Do they have any vascular abnormalities in their brain that's caused them to bleed? Because the brain does not like blood. Doesn't like blood, hates it. Blood is an irritant. So if there's blood in the brain, it's going to like to seize. Do they have an infection? Meningitis, encephalitis, those bugs love to cause seizure, especially HSV. That HSV loves to seize. Trauma, any head injury, you get that contusion, that can lead to a seizure. Autoimmune, that can also, body is creating antibodies to attack itself, and sometimes some antibodies can attack the brain. Brain doesn't like it, so brain will seize. Metabolic derangement. Some of the key electrolytes that can lead to seizures are glucose, hypoglycemia, hyponatremia, and hypernatremia. Those are the big ones that can seize, and so many other ones can too. So we like to check, get a BMP, get mag, get phos, get calcium. Calcium, like, not so much, but yeah. And then idiopathic, this just means when we don't know what did it. Just, that's like a diagnosis of exclusion. And then cancers, brain cancers, I've seen it a lot, can cause seizures. So that's why they got the MRI to look to see if there's any tumors in the brain. And then what do they mean by syndromes? I guess like epilepsy syndromes. So yeah, so when you're convinced a patient has a seizure, you want to work through, these different etiologies to figure out why they seized.
With the syndromes, I think they're pointing to like those very rare things that I honestly don't see very often, but like those Sturge-Weber things, tuberous sclerosis, those things that like they're like a very textbook case, even some like Down syndrome though too. I think that's what they were sort of going with the syndrome. Von Hippel-Lindau or something like that. Like those are like they cause these like tumors in different areas of the like Gardner syndrome. In fact, these are very step one stuff actually, like having to identify these patients, not based on seizure more so, but based on like the syndrome like VHL. But yes, I think those are more so what they were referring to as far as the syndromes with seizures.
Thanks. Cool. Awesome. So that is what I have for you all. Does anyone have any questions before we get to TBI cases? And then what I plan to do now that we've kind of ran through the basics, for the next week or so, we'll do a lot more like seizure cases, and we, work through it together, and we talk about different things, and yeah, like more so focusing on like emergency room seizures. Fantastic. Let's talk about some brain or some TBIs, and then I'll help you run through it too, Seema.
I'm presenting. Okay, mine is not going to be as fancy as Dr. Guitarist.
Oh, it's all good.
If
If you just have like a case or a couple of cases, and I can also look through some cases too, and we can just work through it together.
Sure. Yeah. Let me just share my screen.
Cool. I think I'm gonna have to make you. Are you able to share your screen?
No, it says host disabled.
Oh, okay. Let's try that now.
Seema, I would love to know, do you work in the ER or as a neurologist? Or it's always good to have
I'm an
perspective.
IMG applying for NeuroMatch. I'm working in lab medicine currently just to keep myself busy. Yes, but I'm interested very much in neurology. I'm in the oncology side right now, so working in oncology.
Okay, awesome. Thank you. I'm an IMG also. I just realized that. I'm like, oh yeah, I go to Ross University.
Oh wow, nice. So I just pulled this case online. Are you able to see my screen, guys?
Yes.
Okay, let me see. Okay. So this is a fictional case. Let me see. Okay. Of a patient of a 65-year-old woman who presented with a TBI. She underwent, I don't have any case history for her.
Oh, there's the case. Is it 65-year-old
This
woman?
one? Yeah, okay, yeah. 65-year-old woman was getting groceries with her friend when she slipped on ice, hit her head, and lost consciousness. Ambulance was called and she was rushed to the hospital. The patient lost consciousness for 1 hour and remained in an altered state of consciousness for 24 hours. Diagnostic imaging confirmed right-sided focal subdural hematoma. Her GCS score was 9, E5, M2, V2. And she presented as a level 3 on Rancho's Los Amigos scale. I don't know what this is.
Me either. I have to look that up. And then
Never heard of it.
So we can let's break down this case. So she's a 65-year-old female
Mhm.
getting groceries, slipped on ice. That happens all the time. People be careful.
Rochester.
Yes, you guys, it's snowing. It's snowing right now.
So you should come to California. We have
I
nice weather
know.
like that.
I should. I was talking with Gabriella earlier, and she was telling me how it's 20 degrees Celsius, and I think that's like 70 degrees Fahrenheit. She's
I
like,
am in California, so I can make you more jealous.
oh, what's the temperature there right now? You know, she said it's so
Yeah, it is
cold.
about 70.
Oh my gosh, I just don't want it to snow anymore. That's all. But yeah, people, yeah, you got to be careful, especially here, because we get a lot of people in the ED because they slip and they get a brain bleed. So she hits her head and loses consciousness.
For 1 hour, remained in unconscious for 24 hours. Altered state of consciousness, not unconscious, sorry.
Wow.
The CT showed right-sided focal subdural hematoma. GCS was 9.
So what's high yield on step 2, step 3 is they love these brain bleeds. So how does a subdural hematoma look like on a CT scan?
Crescent shape.
Yeah. So be sure that you guys know how to identify epidural, subdural, subarach, and intracranial hemorrhage. So for epidural, what's the common cause for epidural hematomas?
Very, very classically, they love the middle meningeal artery injury there that causes the epidural hematoma, which presents on CT with this sort of lens shape presentation with specifically a lucid interval.
Yes, yep, that's very high yield. What's the artery or what's the vascular that presents, or that's the etiology for subdurals?
Subdural, they love the bridging veins.
Yeah.
So disruption of like the bridging veins. Mm-hmm.
So yeah, so Seema's pulling up what it looks like on CT. So that's high yield. Like I've seen that on my shelves. Step 2, step 3. So know that image. No, that is typical. You see that hyper dense region on the left side, hyperdense. It's crescent shape. That is a subdural, and that is because of bridging veins. So you know that. That's high yield.
This like you said, it just never goes away. It's like on step 1, it's on step 2, it's on shelf, it's on another shelf, and it's on the next. And actually, another thing with subdural, they love the falls. Like in this case, they love like the old person that falls. They love the alcoholic that is like more confused than usual, and just 2 weeks they've been, they love the nursing home people that fall. It's like everything is, they just love these subdural hematoma cases.
And so why do you guys think after she fell, she lost consciousness?
It looks like we've got some herniation on this particular, I'm sorry, so we've got a little bit of
this is just a
midline herniation to the left side.
Yeah, this one does have, yeah, you're right.
So I'm guessing that in order for someone to lose consciousness, there's certain etiologies in the brain that you have to hit. And so she probably has mass effect because of the hematoma, probably has swelling, and probably has herniation, and that's why she was unconscious for so long. So that's just a really good case. She had a traumatic brain injury. Surprised she didn't have any skull deformities. And we really counsel our patients, especially those who are on anticoagulation, especially warfarin, anticoagulation, that they have to be extremely careful, because I don't know if she was on anticoagulation or not, but that can cause deadly brain bleed. So we always counsel patients to be very careful with falls. Awesome. So we talked about loss of consciousness and sorry, go ahead, Seema.
No, keep going. The next is the GCS scale was 9.
Okay, so let's look up MD Calc and GCS, because I can always use a reminder.
So
I always shows up on step 3.
Yeah, and I always love going 4 eyes is 4, mouth is 5, which is verbal, and then 6 is motor. So it's like
Yes.
4, 5, 6.
4,
Yes, 4, 5, 6.
5, 4,
and then
5, 6.
Yeah. So, and then the magical number as far as intubation, I always say, like, the trick is like, if it's less than 8, intubate.
Okay, let me write that down.
Like, it kind of rhymes. Less than 8, intubate.
Less than 8, intubate.
So, and that can come up, I'm sure, on any exam. If you see that GCS is less than 8, intubate is like the first. What's the next step?
Less than 8.
Probably not a step 1 question, but certainly shelf step 2, step 3s, and beyond. Less than 8, intubate. Less
than 8, intubate. 4, 5. I like that. 4, 5, 6. Okay. 4, 5, 6. So she scored a 9. What was her score? Where did she score?
And the highest
She was
15. A GCS of 9 is
9, E5, M2, V2. So she doesn't have a verbal response, no motor response, but eye movements are fine.
Okay.
So that's actually important, because knowing that, and the reason why they correlated that to TBI being classified as moderate, because my understanding is 8 and below is considered a mild, like a GCS is 8 and below is considered mild TBI. 9 to 11, yikes, 11 or 12 is considered moderate, and then like either 12 to 15 or 13 to 15 is considered severe. So that's how they came up with TBI was classified as moderate.
I'm getting ready to pull up the TB. Maybe they'll talk about it here too, like the TBI diagnosis. Because I'm a visual.
It's over here. It's actually over here in the same classified.
Oh, okay.
Yeah. So classification of TBI, here we have it. They're talking about different focal and diffuse here.
Nice.
So the different classifications for diffuse, we have concussion, diffuse axonal injury, blast, abusive head trauma, shaken baby syndrome. If it's a focal, it can be the contusion, penetrating hematoma. Hematoma, again, 3 subtypes: epidural, subarachnoid, and subdural. Or it can be intraventricular, intracerebral, or intraparenchymal. And then there's the secondary brain injury.
Can you send this link in the chat, please?
Yes.
Thank you.
What does I would love to, like, what does actual like diffuse axonal injury look like on CT? Like, what does that actually look like? You know, I know like the buzzwords that they mention, like, oh, like diffuse axonal, you're gonna have like punctate hemorrhages, and there's a lot of like maybe edema or swelling. What is it like? Like if I see a CT, I want to like know how it looks like. That is, you know.
And basically, you know how when you look at a normal CT, you have a beautiful gray white matter differentiation. With diffuse axonal injury, you lose that. Like the gray and the white, it all merges together, and you can't really tell
This one?
what is what.
Do you lose
Diffuse
like the
axonal
gyri and the
injuries.
sulci?
See here, there's a picture.
So let's look at the, let's see.
So you kind of lose the gyri and the sulci, basically. as
So
well.
here they talk about a 19-year-old male patient with diffuse axonal injury. The first A is T2, and it says it's insensitive to hemorrhagic lesions. The B is T2 GRE. It shows numeral foci of signal loss, which are encircled here. You see these dots. In subcortical white matter corresponding to areas of extravascular blood, and susceptibility weighted imaging, that is C, is even more sensitive than previous two sequences, exhibiting more conspicuous circles and numerous lesions, squares. So yeah, these were not picked up before.
So
On both cerebral hemispheres, yeah. You can see here, this is not there.
wow. This is great. This is a great resource. Let's see, what else did the case talk about? What else should we, they mentioned some, what was it? Some scale that I wasn't familiar with.
Yes, Rancho's Los Amigos scale. Let me click on this.
Oh, okay.
So this is also known as Rancho Scale. It describes the cognitive and behavioral patterns found in brain injury patients. It was originally developed by a team in Rancho's Los Amigos Hospital in Downey, California. Consisted of 8 levels, later on revised into RLASR. I'll skip to the functioning. So it had originally 8 levels. Revision has 9 and 10. So this is the inferior functioning, which is the 1 to 8. Superior functioning are the 9 and 10. Okay, let me see if I can find a table. Okay, here, level 1 is no response. Level 2 is generalized response. Level 3 is localized response. Level 4 is confused, agitated. 5 is confused, inappropriate. Level 6 is confused and appropriate. This is a bit confusing. Level 7 is automatic, appropriate. 8 is purposeful, appropriate. What's the difference between 6 and 4?
You know, it's interesting because the hospital that I had been at for years, like this was a part of the EHR. However, it wasn't really actually, it was documented from the staff by the nurses, but it wasn't really used in a meaningful way, if that makes sense. So like in the case that, okay, now it's time to do multidisciplinary rounds, you know, grand rounds, it was GCS. What's GCS? You know, so it's I don't know. How do any of you guys see this scale actually being
This is
like
the first time I'm hearing it. I have no idea.
Same here. But maybe it's something we should be using. Maybe like the TBI experts. I can ask my sister to see if they use it in the ED. But that's like an interesting behavior. Cool.
Okay. And the severity of TBI is classified as moderate. So I think you were explaining about the TBI classification, right, Laura, based on GCS.
Ah. Oh.
We have another one here, classification of TBI severity. Yeah.
Thank you.
So classification, if there's a structural imaging, in moderate and severe it can be normal or abnormal, whereas mild, it's always normal. Loss of consciousness, it's about 30 minutes in mild, less than 30 minutes, but no, sorry, more than 30 minutes, but less than 24 hours in moderate. More than 24 hours is severe. Alteration of consciousness or mental state, it can be a moment in up to 24 hours. More than 24 hours, severity based on other criteria. Post-traumatic amnesia, PTA, is 0 to 1 day in mild, more than 1 day, less than 7 days in moderate, severe is more than 7 days. And GCS, this is the one Laura was talking about, is 13 to 15 in mild, 9 to 12 in moderate, less than 9 is severe.
Thank you. I'm glad that clarified that, because I think I had like the 12 and 13 confused. So yeah, so, and actually, yeah, so less than 9 is severe, not less than 8. Perfect. Okay. And then 9 to 12, 13 to 15. Perfect.
So going back to the case, the patient underwent a craniotomy the following afternoon. After 2 weeks in the ICU, the patient's functional independent measure score improved from 57 to 68. What is functional independent measure score?
I have never heard of that, but I wonder if is that specific for TBI patients?
I'm wondering if that's like a score or scale that's kind of being readily used in like rehabilitation centers. I don't know. I've actually never heard of it. Or if it's TBI specific, I don't know. I'm kind of wondering.
So it's an instrument that was developed as a measure of disability for a variety of population, not specific to any diagnosis. It it is designated to assess areas of dysfunction in activities that commonly occur in subjects with any progressive, reversible, or stable neurologic, musculoskeletal, or other disorders, that is, patients with functional mobility impairments. It's basically for the functional status.
And I feel that they're different kinds of functional status or status scales, but it's good to know that, you know, this one can be used because it sounds like it's very comprehensive.
Yeah, it has like communication, social cognition, locomotion, transfer, sphincter control, self-care. Yes, yeah.
So this certainly looks like something that physical therapists and occupational therapists heavily use, or at least are familiar with, more so than maybe like the people in the inpatient setting. Because the reality is, like, with TBI patients, rehab is a big part of their plan of care, both motor and speech. Unfortunately, cognitive is something that I haven't seen to have the biggest improvement. You know, because it's hard to have like cognitive rehab is certainly a lot more difficult. Like, people can get their mobility back, people can have the speech back, but like that cognitive slowing, that impairment in judgment, impulsivity, so the sight component of it, like the mood stability is so much more challenging. So this certainly looks like more on the rehab on the more physical side versus the cognitive.
And it's hard, and I hope that you're right in that it's really hard to rehab the cognition from the TBI, because I've had patients that have had, usually the patients I see after TBI is for like recurrent headache or dementia or the cognition, and it's hard to read. There's not a lot of resources available for patients to help with bring back that cognition. But
You're so right.
a lot of work that's being done at one of my good friends is, you know, traumatic. There's a lot of research that's being done in traumatic brain injury and plasticity and like regeneration of neurons. And hopefully, you know, from the molecular physiology level, once we understand, then we can take it to like, you know, the more functional level. But I think we're still at the molecular level, really trying to understand what's going on in patients that have traumatic brain injury.
Yeah. And in fact, like the experiences that I've had as well, it's actually it is really, really sad just because like I find that a lot of the TBI patients they're young, they're healthy, they're athletes, they motor vehicle accidents, you know, and then it's like their whole like, it used to be like this young jock and now it's like trying to get back to the baseline is such a challenge. So
does anyone hear that in the background?
I do so, yeah.
Text from once. Yeah.
Try. We can take turns muting ourselves, see if it goes away.
I don't hear anything now. Do you hear anything?
Oh,
Seema, I think it's you.
Seema, I think it's coming from you.
Oh, from me?
Yeah.
Oh, let me see if I can join through my phone.
It's maybe because sometimes if your phone is like too close to the computer and you're zooming, I don't know. Who knows?
How about now?
It sounds amazing. I don't hear anything. Sounds great. Thanks.
Okay, I switched to my phone. Okay. Can you guys hear me now?
Yeah, you sound great.
Okay. So yeah, let's continue, or does anyone have anything else to share? So the patient presented with 7 days of retrograde amnesia. But they're only talking about the rehab part. I think I'll pull up a different case.
Cool. Nice. That was a great case.
Yes, I found one more here. This is on the PubMed.
Nice.
So this is a case about bystanders found a 28-year-old unhelmeted white male prone and unconscious after he had lost control of his motorcycle and went off the road. He was brought to the ED via ambulance, intubated as a level 1 trauma activation. The physical examination revealed a GCS of 3T, 4 millimeters bilaterally fixed pupils, negative corneal response, right parietal cephalohematoma, and CSF otorrhea on the right.
So let's pause. So that's a lot heavy thing, a lot of great learning points. So 28-year-old, he's unconscious after a traumatic motor vehicle accident. And the ED, his GCS is 3. So what does that mean?
That is
severe.
literally that is the lowest level you can go. That's the most severe. Like GCS of 3 is dead, essentially. I mean, let me not say dead, but you can't, like, that would be, well, I guess dead people would have a GCS of 3, but like in this case, this is the most severe number you can get.
So that means he's not having any he doesn't have a motor response. Hold on, 4, 5, doesn't have eye response, mouth speech, motor, and pupil.
Yeah, there's no eye, there's no verbal, and there's no motor. So that gives you 1, 1, and 1.
Yep, good. And then what's the T stand for?
I have no. I was gonna ask you. I was like, what is that about?
Is that intubated? Like 3T? I think the T is for intubation, right? Let me look it up. Hold on.
That would be a wild guess for me. I have no idea. I've never seen it been presented like that. It's so, I want to sound really cool on the units, like, hey, he's a 3T. You know what I mean?
Yeah.
It just says bad prognostic factor, but due to a blunt trauma. Okay, here.
So 3 is deep coma or brain dead state. So there you go. That's more appropriate than me just saying dead. But
Yeah, intubated patient. Yes.
okay, I'm gonna start saying T. He's a 8T.
Yes. Yeah.
Let's see what else. So now we get into our favorite localization. So 4 millimeter bilateral fixed pupils. Let's break that down. So when you shine a light in someone's eye, their pupil is supposed to constrict. So when the physician's doing the exam on this gentleman, they shine the light in his eye, his pupils are not constricting. So what does that tell us? So when your pupils constrict, dilate, that's really cranial nerve 2. That's
2? I thought it was 3.
3.
Oh, so
2 and
it's
3.
not oculum. 2. It's 2 and 3, right? Like
Yeah.
you have the coming in, which is the optic, and then the oculomotor giving you the dilation constriction. Oh, I've never been good with the eyes with neuro. I thought it was the
Let me find it in my notes.
the afferent limb and the efferent limb.
Yeah,
Yeah.
I think it's
So,
I think it's 2 and 3. Hold on. Let me find my notes.
Afferent, it would be the would be 2, yeah, and then the efferent would be oculomotor, the cranial nerve 3, 4, and 6, or 3.
You're talking about the 3, 4, and 6, right? Like it
Yeah.
goes, Ducens is 6, and
Okay.
Is 3. Yeah.
I'll share this with you all. So
Here,
this is,
I'm going to stop sharing. Go ahead.
thanks. Share. So here for the brainstem reflexes for the pupils. So what happens? You have the pupillary light reflex. You know, it goes into the light goes into the eye, then it goes to the optic tract, goes into the midbrain, pretectal area, then it Edinger Westphal nucleus, then it goes into the optic nerves, connecting with the constrictor pupil, whatever. So that's going to be 2 and 3. So pupils 2 and 3. And then here's a more simplified version. Light reflex is cranial nerve 2 and 3. Light impulses, blah, blah, blah. So light is shined into either eye, causes simultaneous stimulation of cranial nerve 3, which makes the pupils constrict, but pupils, blah, 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 blah. Okay, so 2 and 3. That's the big thing to know. 2 and 3, cranial nerves. I just love localization.
I've never been good with neuro-opta. Like when I say like I could never, like I'm like once you get past afferent and efferent, I'm like, and like
Either.
It's tough. So thank you for breaking that down.
Yeah, no problem.
So going back to the case, negative corneal response.
Oh, so where does that localize? Cornea. Where's that? Basically, you take a tissue and you rub it on the surface of their eye, not the white part, that's the sclera, the cornea. So this person has an abnormal corneal response. What would that look cranial nerves?
Is that, oh wait, it's either 3 or 7, right? Oof.
So
Here.
What cranial nerves are responsible for touch, sensation of the face?
Oh, 7th, yeah, so 7.
5.
Okay.
5.
Wait. Oh, you're talking about V1, V2, V3. Oh,
Yeah.
yeah, but I thought corneal response was 7 though.
The touch is all 5,
Oh, okay.
right?
Yeah.
Oh, wait, you could be right. The 7th is blinking.
So the touch itself is 5, and
5.
then the blinking is 7. So it's going to be 5 and 7. So that's going to localize to the pons. So let me, I'm going to share this with you guys real quick. This has helped me go back through my notes because I forget some of this. You guys see my screen?
Yes.
So corneal reflex, so you can take like a tissue paper or saline drop and you drop it right at the surface of where the iris is, right on top of it. And sensation in the eye is transmitted through the trigeminal V5 nerve. Sorry, trigeminal nerve, cranial nerve 5. And then that goes into, V1 branch. And then that gets transmitted, and then that's the afferent response. Then the efferent response is, the patient actually squeezing their eyes shut. And sensory to the face is cranial nerve 5. Facial expression is cranial nerve 7. But those are like the big splits. So the big things for the students to take away here is touch of your face is cranial nerve 5. They love that on step 1. Cranial nerve 5. There's touch of your face. Anytime you smile, you blink, move, you eat, for the most part, it's going to be cranial nerve 7. The tongue gets funky and different, but I won't complicate you guys with that. But for the most part, sensation of your face, 5. Moving your face, anger, smile, happy, sad, 7.
The way I remember is Bell's palsy, drooping of eyelids, 7.
Yes. Yeah. Awesome, then. So this means now that the reason why it's important to do the cranial nerves is because we are localizing. So we know that his cortex is shot. He's unconscious. So that means he doesn't have any cortical response. He's not alert. So by doing the cranial nerve testing, it tells us it localizes. So his pupils are fixed. We said that's cranial nerve 2 and 3. That's midbrain. So that means his midbrain is affected. He doesn't have a corneal response. That's 5 and 7. That's pons. Pons are affected. So let's see. So his midbrain is he practically has no brainstem reflexes. So he's brain dead. If we did breathing and other things.
And he also has a right parietal cephalohematoma, CSF arteria on the right.
That's bad. So he's leaking CSF into his ear.
Would that be like a basal skull type of fracture situation?
Yeah.
Okay.
That's bad.
Which they love that stuff with the raccoon eyes and like the what is it called? The bruising called here, the ecchymosis at the mass what is this bone?
Right here?
Yeah, like not the occipital, but like right behind the ear, like the
mastoid process?
Mastoid, thank you. Like that's called some sort of sign, like raccoon's eyes with the ecchymosis on the eyes, and then bruising right behind the ear as well. Like those are like signs of basal skull fracture.
Yeah, that is high yield. I have seen that on shelf and step two more so.
Okay, so CT of the head showed subarachnoid hemorrhage with left frontal temporal subdural hemorrhage. So we have a figure here. Which is this?
So while that's coming up, what is the most common cause of subarachnoid hemorrhage?
Hypertension.
Aneurysm. I just learned it from Dr. Igodoro.
Yes, it's the most common cause is trauma. The most common cause of subarachnoid is trauma. The most common cause of non-traumatic subarachnoid is rupture of berry aneurysms. Seema, for hypertension, that would be intracranial hemorrhage or each intracerebral deep subcortical hemorrhage.
And ischemic stroke.
Yeah, yep.
So this patient has left frontal and temporal subdural hematoma.
Wow.
This one right here. This one.
Yeah, this is a heavy case.
All these little arrows. I don't know if you guys can see the arrows.
Is the image is the image coming up?
Yes. Let me
Do
see.
you see it on your screen?
Yes. Can you see now?
No. Oh, we see it now. I see it now. Ooh.
So it's all over here, here, here.
Yep. And you note here, his ventricles are very small, especially the lateral ventricles. So that's probably signs of edema, swelling. He has a little bit of a midline shift over to the left.
Right. Oh, I thought it was more to the right.
Oh, sorry.
Left
You're
to
right.
right.
You're right.
Right, yeah.
My bad. You're right. So yeah, this is yeah. And then you can see, you see how you can't really differentiate between the gray and the right. Unlike with the normal CT, like it's kind of blurry. It's kind of just, it's all fuzzy, like a television, fuzzy, hazy. So he definitely has diffuse axonal injury.
So what are we thinking? Intubate, hyperventilate, mannitol, and do a pick cranie or
Yeah.
burhole? Do you like burhole? Y'all want to do a burhole?
Me, that's a surgery question, but definitely I would be calling surgery. Definitely intubate. That's ED, folks. But I think the role that neurology play is hyperventilate, bed set, 3rd degrees.
3rd degrees, yeah.
Or osmolar therapy.
3%. Oh, they're saying here hypotonic 23%. Wow.
Yeah, it
Okay,
depends.
so I thought it was.
It depends on the hospital.
Okay. I'm just used to using 3%, so I'm like, ooh, this is a different dose here. Okay.
Oh, but let's look at the other images, like figure 2 and figure 3.
So the figure 2 is effacement of suprasellar cistern, which is this. Let me see if I can share it. Can you see the image?
Mm-hmm.
Yeah. Oh, wow.
Yeah, so you really can't see his ventricles. They are swollen.
Yeah. And going back to figure 3. So this is effacement of 3rd and 4th ventricles, which is this. Yeah.
Mm-hmm.
In addition, CT showed left frontal, temporal, and parietal hematoma with mass effect, cerebral edema causing a 5.38 millimeter left to right midline shift, which is in the figure 4.
And this is why he's unconscious, because that mass effect, the edema, midline shift. Yeah. Yep. Bad. This poor prognosis. This is why you should wear your helmet. And I'm gonna have to admit, I don't wear my helmet, but it's not my fault, because when I wear my hair natural, it's the helmet people's fault, because they don't make helmets that fit my hair. So what am I supposed to do? Not ride my bike? But I have reached out to some of these helmet companies to, but no one's getting back to me. But I'm putting myself in danger every time I ride my bike without a helmet because I see it in the emergency room, in the ICU, or you know this better than I do. But you can't person without a helmet on a motorcycle and you got a 2-ton cart coming at 50 miles per hour, you don't stand a chance. So wear your helmets. I need to go wear my helmet. I need to go find a helmet.
I like love this bike safety though. I love that. I commute by bike and I'm a cyclist in a cycling club. So I'm really into that. So I'm like, look at you. I love that. Yeah. Yeah. Bike.
I'm trying. That's the only way I get my exercise.
Nice. He also has a frontal skull base fracture and a complex non-displaced comminuted fracture of the right temporal bone. Do you want to go back to the picture or
No,
just
that
imagine?
looks great.
He was bradycardic with his lowest heart rate recorded at 28, hypertensive with an initial BP of 172 over 118, and markedly elevated BP of 221 over 105, 30 minutes after his arrival at our facility.
Okay, so let's stop here. Let's look up Cushing response because I can't remember.
Hypertension. You read my mind. It's bradycardia, bradydyspnea, and hypertension.
So your blood pressure is up.
Blood pressure is up, heart rate is down, respiratory rate is down. So this is, I was like, oh my gosh, I smell Cushing's reflex.
Yeah, that's what that sounds like. They don't give us his respiratory rate, but he's probably intubated. But yeah, that's what that sounds like. That's not good. Do you know why? I can't remember. I read it, but I can't remember why that happens.
There's an increase in intracranial pressure.
Okay.
So all that pressure.
Thank you. And so the heart thinks, oh, blood pressure is high. I need to decrease the heart rate to decrease cardiac output.
All that.
Oh.
So it is. Yeah. The increase in intracranial pressure, you'll cause, yeah, exactly. It's a whole reflex compensatory mechanism. Yeah, when you see that, you think Cushing's reflex increase in intracranial pressure.
I see. Thanks.
This is actually very helpful to read the cases this way.
Yeah, thanks for picking such great cases.
Thank you. So he required atropine push and nicardipine infusion. An arterial line and a central venous catheters were placed for fluid and medication administration. Emergent treatment for herniation syndrome included endotracheal intubation, 30 grams of IV mannitol, hypertonic solution of 23%, weight and volume sodium chloride, left-sided decompressive craniectomy.
So let's stop here. So we figured out that this gentleman has increased ICP due to traumatic brain injury. So what they're doing now is they are using different treatments to get that ICP down. So some of the big things, like Laura talked about, is hyperosmolar therapy. Different hospitals have different medications, but some of the go-to is mannitol, which is osmolar. So what happens is mannitol is like a heavy solute. When you inject it, it withdraws fluid from extravascular spaces, and then it takes it down and you pee it out. So people that are on mannitol are going to have increased urine output. Hypertonic saline does the same thing, draws fluid out from the extravascular spaces, because what we're trying to do is we're trying to remove fluid from the brain, all the swelling and edema, and you pee it out. And they're doing the left decompressive craniotomy, again, to reduce swelling, because if that brain continues to swell, it's going to cause a lot more contusions, because that skull is fixed. That skull is not moving, it's not going nowhere. So you have to reduce the swelling, or else the patient will continue to develop consequences, herniation, and then death.
Something to just be mindful of with mannitol or anything that's a hyperosmolar sort of medication is like CHF, pulmonary edema as a result of the medication. Of course, you have to treat what's the number one priority in this case. Obviously, all that doesn't matter if you don't have a working brain, but just something to kind of keep in mind if all of a sudden in 24 hours you're like, oh, here's some crackles in the lung, sounding a little wet. So it's most likely due to the mannitol, especially if they have underlying heart conditions.
That's a good point.
Okay, so post-op, an external ventricular drain was placed. Initial intracranial pressure, ICP, was 14. The patient was examined post-op and also after the EVD placement. The GCS was now 5T.
So let's stop here. ICP, we want it to be less than 20, right, Laura?
Yeah, I thought so. And I'm
Yes.
like, wait,
Yeah.
but this initial intracranial pressure is actually in normal range. That's throwing me off guard a bit.
But sometimes they do it in like millimeters of mercury and centimeters of water. I don't know what the conversion is. But
they did, is this after he received
Yeah.
treatment?
I think
Okay,
so. Yeah.
Fair enough. So that's not true initial then. It's just, it's
After the
the first
post-op.
reading.
Carolina, a lot of this is you're not expected to know for step 1, step 2, step 3. A lot of this is resident level. So FYI, FYI. Did I say your name right? Okay. So
Yeah.
then they placed an external ventricular drain. That's just some tubes that they
They go to the lateral ventricles, right? That's where they sit, the lateral ventricles.
Yeah,
I think I want to say so. I want to say.
I believe you.
Please don't. Do not trust me.
I'm like, that's neurosurgery. Y'all
Oh,
figure that.
no. I'm not lying. Look at that. Look right here. No. CT was said should improve in a midline shift. Ventricular catheter was found to be proper placed in the frontal horn of the right lateral
Here,
ventricle.
we have
So,
a picture. Yes, yeah, we have a
so
image
I
here.
wasn't lying too much, I guess. Lateral
So-
ventricle.
This is figure 5. Oh, this is the broken fracture part.
Craniotomy.
No,
yeah.
that's where the craniotomy where they took the piece.
Oh,
of
sorry,
the
yeah,
skull.
craniotomy, yes,
Yeah.
yeah. And this is, oh wait, this is the one with the ventricular drain.
Well, if
Midline
you
shift.
scroll to 6, if you scroll to figure 6, and you see that white thing in the ventricle on the right side, that's the drain.
Yeah.
Perfect. So yep, right in the right horn, lateral ventricle. Love that. Look at that brain swelling.
I'm surprised he improved. So let's talk about his symptoms. So initially he had a GCS of 3, now it's 5. His pupils are reactive.
Mhm,
So
and
that means,
positive corneal reflex.
yeah, so that's improvement. So that's good.
So CT head showed improvement of midline shift, which is figure 5. Ventriculostomy catheter tip was found to be in the proper location in the frontal horn of the right lateral ventricle. The patient was then started on 3% NaCl continuous infusion. ICP and cerebral perfusion pressure displayed normal values at 3 to 4 and 70 to 75 millimeters mercury respectively. So here intracranial pressure is 3 to 4.
Patient was then started.
For the first 24 hours.
Oh,
with the
okay, this is CCP. So, his ICP is 3 to 4, CCP. Oh, that's low. I wonder, that's low. So that's probably why they're playing around with the EVD measurement. So basically, you don't want it to be too low because then you can get brain sag. I think and Laura, tell me if I'm wrong, I think anything lower than 5 they're like, okay, we got to change the EVD because you need some kind of perfusion pressure in the brain to keep the brain, you know, where it's at. And if you have too much, if you have too little pressure, then the brain will literally sag, and it'll sag and it'll start to like herniate down through the skull, and you can cause compression of the cerebellum. So
Yeah, no, totally, completely. And just to sort of add, as far as like the ICP pressure, like there's goals to like, and I don't know the exact numbers. This is like a super neuro ICU question, and it's in the protocol, so I don't have memorized, but like you can't drain too much CSF in one, like it's kind of like when you drop blood pressure, you can only drop like by 10% every blah blah blah. Same thing applies with like CSF. CSF is made, absorbed, reabsorbed, and like, you know, and flows, and like you like there's only X amount of CSF made produced per day, and so you can't drain but X amount per minute or per hour, or so the EVD is adjusted in such a way where they measure all these things, and the physician, the neurointensivist, then comes in and like adjusts the EVD and places in such a way where the CSF is only draining at a specific rate, and then like based on it's a lot of calculations involved. So an ICP of 3 or 4 is actually on the lower, and that's, I mean, you don't want those drastic drops. But like I said, I don't actually know the number, but I actually now recall that CSF number is actually a step 1 question. It wasn't super in depth, that it was like, you know, it's kind of like you have to know how much CSF is produced in one day, and therefore you don't, you know, remove X amount per hour per whatever. Like, so anyways, but yeah, I'm pretty surprised at and then the perfusion. I'm just a little bit surprised at the significant drop there.
Okay. Let's see. It says on hospital day 2, the patient's ICP was elevated in the upper 20s in the setting of shivering, hypertension, and fever, which were controlled with increased sedation, nicardipine infusion, and targeted temperature management, respectively.
So in this, what is this called? There's a word. Oh, what is it called? Oh, I remember we thought one of the patients had it in the setting of ICP. You can get this, you know, fever. It's not central fever. There's a term for it where you have if I remember it, I'll let you guys know. But it's like, oh, why is he septic? And maybe it's between sepsis versus central fever. But I think it might be central fever. But there's a word for it. I can't remember. But yeah, the symptoms of shivering, hypertension, and fever, some could think, oh, well, is this person having an infection? And it's like, no, their ICP is elevated. And once you rule out causes of infection, it's due to just elevated pressures in the brain that's causing these symptoms. And so once you control it by doing the sedation, reducing the blood pressure, and target temperature management, it's gonna bug me.
Which you say you guys don't do at your facility, the targeted temperature management.
No,
which is
not for only
super interesting.
Only for cardiac arrest.
Yeah, and the old school term for that used to be therapeutic hypothermia. This is like a super, really particular, really intricate sort of 24, 48, 72 hour process. I mean, this requires 2 nurses to 1 patient. I mean, it is a very aggressive way, but like you said, it's I've seen it used in neuro, but mostly it's used in patients who achieve ROSC, ACLS.
I see.
That's good to know. So repeat CT revealed cerebral edema in evolution with no worsening midline shift or hemorrhage. So now on day 3, GCS has improved from 60 to 80 with intact brainstem reflexes. The next day, which is the day 4, the patient's oxygen saturation dropped from 96% to 87%, requiring an increase in fraction of inspired oxygen, that is F1O2, from 50% to 80%, and positive and a PEEP. Respiratory cultures were obtained and chest X-ray revealed worsening bibasilar opacities.
It was worsening by basilar opacity, which could be certainly a couple things, but certainly
This is
we're
on
talking,
day 4. Yeah.
yeah, we've got fluid in our lungs.
Yeah.
Or more
Or-
likely, oh, can you scroll up? So right now he has what we would call acute,
ARDS.
ARDS, acute respiratory distress syndrome. I
would have to see, but I think one criteria, what you need the pressure for the left atrium, the PC, WP, what is it called? The Swan-Ganz catheter to measure the pressure in the left atrium to see, or no, not really.
Yeah,
Okay.
not for ARDS, because it's more so like it's an imaging finding. If you have like whiteout of your lungs and you require more FiO2, that's pretty, this is
classic.
Actually step 2, step 3 question. That's the diagnosis and then there's like different stages, mild, moderate, severe, based upon how much FiO2 you're requiring on vent. So yeah, so some of the etiology, this is getting outside of my expertise as a neurology resident, but whatever I recall from step 1, step 2, step 3 is when you see white out the lung, you think, like you said, edema or infection. So that's why they're getting cultures, they're getting an X-ray that shows bibasilar opacities. And yeah, start them on antibiotics and you're covering here for MRSA with the IV vancomycin.
I'm actually surprised they're only doing Vanco. I'm surprised they're not doing Vancomycin.
Yeah, and really, I thought about that too. Maybe hospital protocol, something you go based on what's common at your hospital. So maybe.
Here, let's take a look. Where is this case from?
I mean, this patient is,
Phoenix. John Lincoln Medical Center.
But I'm just surprised because this is what I would think to be considered a patient that's SAS, sick, blank, sick. I can't say these words on camera, but
yeah,
this is an SAS patient. So I'm like, wouldn't you just throw the kitchen sink at this patient? And because I'm like, IV Vanc, that's it. Yeah. That just covers staff.
Maybe they have their reasons. But yeah, this is a really good case. Like we're pulling all of medicine up in here.
Cool. So the figure 7, this shows bilateral interstitial infiltrate, left phase atelectasis, and pleural effusion.
Yeah, this guy is sick.
Now, day 5, the GCS deteriorated from 8T to 3T in the setting of elevated ICP.
That makes sense.
During bronchoscopy, his ICP was noted to be markedly elevated to 46. Therefore, 23% NaCl was administered intravenously over a period of 10 minutes. Subsequently, a repeat CT of the head was obtained that showed cerebral edema in evolution and no change in midline shift or hemorrhage.
Yeah, so basically this guy's getting more sick. He has elevated ICP in his brain. They tried different interventions. It's not helping. But it shows that his, so wait, hold on. I think I read that wrong. He's deteriorating because of ICP. They give him osmolar therapy, and CT head shows that his edema is improving, and he doesn't have any midline shift or brain bleed. Okay, sorry. There we go.
Okay, so day 6 revealed the MRSA, methicillin sensitive Staph aureus, and Pseudomonas aeruginosa.
You called it. You called it, Laura.
Yeah, well, the thing is, in the neuro ICU or ICU in general, like I'm just really surprised.
I think sometimes It depends on like, like antimicrobial stewardship, and you don't want to overgive antibiotics to cause resistance. I think it's really hospital dependent. That's my protocol dependent.
Yeah, so repeat CT shows worsening infiltrates and bilateral pleural effusions, which is seen in the next figure. So now they switch the antibiotics to levo and cefepime. Yeah,
so his symptoms are not getting better. He's growing. So this would be a step 1 question, Carolina, for Pseudomonas. Like just knowing, I can't recall it because it's been too long, but like knowing like the different, knowing, I don't know if the chat shows up on recording.
It does or it doesn't? Oh God.
We'll find out. But knowing like the different characteristics of like Pseudomonas and staph, and like, what is it, like the different enzymes and the different colors and all that stuff. They love that on step 1.
Yeah, nosocomial, hospital acquired.
The Pseudomonas, like what's gonna like for step 1, they're gonna, well, I mean, it's not like this is just for testing purposes, yes, but in real life also, like Pseudomonas has a very distinctive smell. It is so distinct. When you smell it, you can't forget it. It is so foul. It is very, I don't know if like sweet / it's like I can't even describe it. It's a really, really, really distinct smell though. And it has like a sweet undertones to it as well. I don't know. Have any of you guys smelled it? I can't describe it very well.
And based on how you describe it, I never want to smell it.
But when you smell it, and it's usually right when when it's like the patient most of the time is intubated, or it's like a diabetic patient with a wound or something, but like Pseudomonas loves it loves anything that has like water, which is why like diabetics in their feet and like the moisture there, or like they love like hot tub examples with Pseudomonas because of the moisture. But like Pseudomonas, it loves wet surfaces, moist surfaces, and it has a very, so in an intubated patient in an ICU, it's gonna be coming from juicy areas, and it's usually either like trach or their oral trachea or their oral tube, oral endotracheal tube. And when you take that, like when you disconnect it just to do whatever cleaning, and you smell that Pseudomonas, it is very distinct.
Is it like smell?
I'm sorry?
Does it smell like grape?
I wouldn't say grape because I do enjoy grape. Let me see if I can actually see if like Google has a better description of it, because it is like, you cannot miss it. It's like that's Pseudomonas. It's kind of like C. diff. C. diff is like once you smell it, like, you smell it.
I have actually smelled it, so I know what you're talking about.
It's funny she said grape, fruity. Well, now it's saying grape in here. Google's saying grape, like fruity grape, and I'm like, ooh, I don't know about grape.
Yeah, I heard it in a class. One of my teachers said, but I've never smelled it, so I don't know if it really smells like grape. But I imagine it's not as good as grape. But
no, I don't know. Tina,
it's
help
like
me out. I'm like,
sweet smell and a foul smell mixed together, something like
yes,
that. It's something like
yes, absolutely, like a sweet, foul, burnt sugar. It's really nasty. It's a really nasty smell.
And I think Staph aureus, the step 1 question is tampons.
Yeah. And yeah, if you read the back of a tampon box, it will actually tell you that as well. Like the staph condition, what is it? The toxic shock, TSS.
Toxic shock, yes.
It actually says, if you ever like have a chance, like read the book, it actually will tell you like a warning. It can cause toxic shock.
Yes. So now going back to this patient, day 8, he revealed an improved GCS of 60.
Do you guys want to stop here? Because we,
Oh, sure, yeah.
it's 10:05. This was a phenomenal case. We can always pick it back up next time and finish it.
Yes, actually sounds good.
Awesome. Well, thanks for presenting this. I'm gonna start looking up PubMed for cases.
I will send this in the chat.
Thank you. This was a really great case.
I loved it. Thank you so much. This was
Thank
awesome.
you so much.
And I hope that we all learn how to better, or at least how traumatic brain injuries present, and then kind of what the complications are. The first case you presented, Seema, that was someone who, recovered, or it wasn't as complicated. Whereas in this case, I mean, this guy is on the verge of, is barely hanging on. So being able to see the different presentations of traumatic brain injuries was really good. Nice
It took
job.
me back.
I like all the
Really took
different
me back.
feedback I got in, like, from the real scenarios to imagine, like, that was very helpful. Yes.
Awesome. And whenever you want to lead a topic, lead a case, just let me know. This is for anyone, everyone. And because, I come up here and lead these cases, not because I'm an expert, but because, it helps me learn it better. And, we learn it together. So this was a great study group. Thanks for coming. Thanks for staying. And I'm working on trying to do one that's more, more consistent, but based upon everyone's schedules, that's what I'll work on. And can't wait to see you all at the next study session.
Yes.
Definitely. Thank you. I loved it. The cases were amazing and I learned so much. Thank you.
Fantastic. I look forward to seeing everybody. And again, if there's topics that so for the next month or so, we're going to be focusing on an ED neurology. So there are topics within ED neurology that you're interested in, that you want to discuss, just let me know and we'll set it up, and we'll do like we did today. Will we help each other get through the case?
Loved it.
Cool.
Loved it. You took me back to the ICU.
Right.
Have a good night.
Bye, everyone.
Bye.
Bye. Good night.
Good night.